Hello, good morning, good afternoon, good evening, everyone. Welcome to our webinar today. We'll be getting started in just a minute or two. We'll give folks a chance to get logged on. While you're waiting, please feel free to type in the chat your name, your organization, and the country you're coming from. And please make sure to select everyone in the chat in the drop down so that everyone can see your response. And welcome again. Welcome again, everyone. We'll go ahead and get started now. Thank you all for joining us today as we share some of our thoughts on how to integrate equity into knowledge management or KM initiatives, and so that we could achieve equitable KM for better outcomes. Today, we have presenters who will be speaking in both English and French. And we are providing live French and English interpretation during the webinar. So we'd like everyone to click on the interpretation icon at the bottom of your Zoom screen and select the language of your choice. You'll then have the option to mute the original audio so that you don't hear that in the background. So just as to reinforce this, everyone should select a language right now. My colleague, Natalie, will also be dropping a link to view the French version of the slides for those who would like to follow along with us as we display the English version. So if you click on the link in the chat that Natalie drops, you'll be able to access the French version of the slides. And we will be talking a little bit slowly to give our interpreters a chance to catch up. And we'll be also pausing before we transition to the next slide. We are providing closed captioning, so if you'd like to see the captions of the session, go ahead. You can go ahead and select that at the bottom of your Zoom link. My name is Ruwaida Salem. I'm a Senior Program Officer at the Johns Hopkins Center for Communication Programs, or CCP, and I'm also the Knowledge Solutions Team Lead for the Knowledge Success Project. I've had the pleasure of working very closely over the past couple of years with Dr. Lata Narayanswamy and Rihanna Thomas. Rihanna is a technical officer at FHI 360, and both she and I work for the Knowledge Success Project. Dr. Narayanswamy is an associate professor in the politics of global development at the University of Leeds in the UK. Her areas of expertise are in decolonizing development, gender and development, knowledge, power, and civil society. And she has been playing a critical and very helpful advisory role on our project to help us think through issues of gender and other types of equity as it relates to our knowledge management work around the world. We're also joined today by 3 additional distinguished panelists who also work on the Knowledge Success Project. Irene Alenga with Amref Health International. She's the KM and Comms lead for East Africa for the Knowledge Success Project. Aissatou Choi with FHI 360 is the KM officer for West Africa for the project. And Grace Gayoso, also known as Gayo with CCP, is the KM officer for Asia. So we're very pleased to have them join us today as well. Before we take a look at our agenda, I wanted to say just a few words about the Knowledge Success Project for those who may not be as familiar with us. So our project is funded by U.S. Agency for International Development, and it focuses on knowledge management for family planning and reproductive health programs, or FPRH programs. In both FPRH and global health programs, we typically think of our audience as women, men, children, people in the community from the general population. For our project, however, and for knowledge management and global health work in general, our audience is the program managers and the technical advisors and other decision makers who design, manage, and lead programs to improve the health of people. So in other words, you all joining here today are probably people who make up our audience. And our goal is to make it easy for you to find, share, and use the information you need to inform and improve your programs, and ultimately help improve and save people's lives. I'd like to take a moment here to also acknowledge all of my Knowledge Success team members, because we've all been working together to learn and discover how to achieve equity in KM and ensure that everyone in the health workforce has the opportunities and resources they need to define and participate in the knowledge cycle to improve health programs. We started on this journey when we conducted a gender analysis to inform the design of our project. That gender analysis made it clear that gender equity in KM was central to achieving better KM health outcomes. But as we continued to reflect on these ideas, we became increasingly aware that gender is one of several overlapping lenses of analysis that are critical to strengthening KM for health programs. All of this was happening at the same time as calls were being made to decolonize global health, and parallel efforts were also being made to address diversity, equity, and inclusion, particularly in the United States where our project is based. These movements help to amplify the importance of addressing the needs of people with historically less power and privilege to reshape the systems in which we work, including our KM systems. And so we attempted to contribute our small piece to this puzzle by developing and sharing guidance and practical tools to helping those who work on KM systems and processes to intentionally integrate equity into their KM initiatives. And that's what brings us here today. Our plan for the session today is as follows. So our webinar is scheduled for 90 minutes. It may seem like a lot of time, but the topics we are covering are pretty intense. And so the time will really not do justice to the entirety of the issue at hand. Dr. Narayan Swamy is going to kick us off by setting the stage and sharing with us a brief overview of historical and contemporary perspectives on equity in KM and why we need to even focus on this issue. Then my colleague Rihanna will dive into how we as a project define equity in KM and share some practical tools that we've recently developed and published to help integrate equity into KM initiatives. We'll then turn to our discussion panelists and ask them to share some common challenges to equitable KM that they've encountered in their respective regions, and also to share some effective solutions to those challenges. We will definitely reserve some time at the end to take your questions, but we also encourage you to type your questions in the chat box throughout the webinar. Our team members will collect those questions, and if possible, we'll try to answer them immediately in the chat, as well as answering other questions verbally at the end of our webinar. And now I'd like to pass it over to Dr. Narayan Swamy.
Thank you, Rueda, for that very generous introduction. It is such a pleasure to be here with all of you. I look forward to interacting over the course of the webinar. But to set some historical and contemporary perspectives on our conversation, I wanted to take some time to reflect on equity in KM. So next slide, please. And to do this, I wanted to go through 4 things. So the first is I would like to spend a little bit of time thinking about coloniality, how our colonial past has shaped our modern present, and then what the implications might be for how we think about equity in knowledge management and health. And then to move on to reflect on gender, sex, and intersectionality. I'd like also to think about how we know development, and I'll explain what I mean in a minute, and then why it's important to focus on equity in knowledge management. I also wanted to flag that there are some upsetting images in this presentation. I don't do that thoughtlessly, and I wanted to flag it in advance, but I do think that if we're going to talk about coloniality, we have to confront it as it was. So that's the reason for putting it in. If that's upsetting, I'm really happy if you want to private message me. I will hang on at the end if anybody needs to talk through anything. Next slide, please. Okay, so the starting point here is really for us to reflect on the fact that colonialism has irredeemably shaped the world. And for me, the takeaway message here is that we mustn't think about the coloniality and the legacies of colonialism as just about distant brown and black others who are living in distant places from Europe and North America, or in the context of Europe and North America, that we're only interested in, racism or inequality. For me, the starting point is that colonialism is our story. It is about everyone. And we must recognize the continuities then in how we know the world and how colonialism has shaped that world. So that's the starting point for me. It's not Colonialism is not just the story of some people in this world, it is everybody's shared story. Next slide, please. So a quick way to summarize the key concerns around colonialism would be to try and draw out the continuities and also the legacies of empire and the ways in which they shape the system within which aid is deployed. So the first thing to say here is that aid as we know it is in fact an extension of the colonial system. Now here I've referred to Britain. It's not because they were the only colonial empire, but simply because they were the largest, they have had some of the most far-reaching impacts. But obviously here, European empire is no less important. And obviously we have the effects of European empire more broadly throughout the world, of course. So what's important then is aid is in fact an extension of the colonial system. Very often it was implemented by redeploying colonial era officers. So your job description before the colony declared independence was colonial officer or colonial administrator. That country declares independence, and now you are simply rebranded as a technical development officer. That's literally what happened in places like Kenya. And then those same people then went on to shape the system, the aid system, in senior posts at what we call the Bretton Woods institutions. So the International Monetary Fund, the IMF, the World Bank, other UN specialist agencies also started some of the large INGOs that have become some of the household names within the aid system. So slavery, land expropriation, resource extraction, they all served imperial interests of wealth accumulation. And that we can see having knock-on effects in terms of our social relations. Now, coloniality has had many other effects, for the purposes of our discussion today, I want to focus on racism and gender. So racism, the idea that Black and brown bodies are incapable of quote unquote culture, civilization, or lack self-control, were all part of the science of eugenics that flourished as part justification for empire. And I'll come back to eugenics in a minute. And then gender, the idea that the norm or default is heterosexuality, consisting of fixed sex categories that set up smallish family units, is a legacy of British colonialism in particular. Alongside this, the criminalization of LGBTQ people is also a legacy of colonialism. Many countries, including India and Singapore, only recently repealed Section 377A, the British Colonial Penal Code, that criminalized all sexual acts that were quote unquote against the order of nature. And that penal code effectively outlawed homosexual relations. So taken together, these enduring perceptions of brown and Black bodies incapable of self-governance and in need of what we might call external guidance, i.e. of the colonial power, turns the colonial enterprise on its head. Instead of imperialism as this story of occupation, violence, and displacement, empire itself is understood as benevolent and emancipatory, supporting primitive, quote unquote, Black and brown others through imperial gifts of railways, governance systems, and common languages, notably English, and I'll come back to that in a minute as well. All of these gifts are helping the quote unquote savages to become civilized. The success of this enterprise is then measured by the capacity of these former savages to liberate themselves from colonialism by using these gifts. Okay, so independence from colonialism and democracy were then granted, the story goes, by European colonizers to their former colonies. So there's a whole levels of erasure that are both gendered and raced. So what are the implications for us now, and why is that relevant to equity in KM in health? Next slide, please. So one of the challenges for us is to reflect specifically on colonial legacies in health, and that should then form the basis for how we think about and consider why equity in KM in health and knowledge management in health is important. So the starting point here is that there is no doubt that Western medicine, defined very broadly, the West is not homogenous, but broadly, if we can talk about Western medicine, has done some remarkable things. That is actually not in question at all. But that has a history that we need to think about. And that history, including its coloniality, has an effect on how we think about health today. So the first is the question of eugenics, or what was known as, and is still called, eugenics is the science of race. And this offered what we might call post hoc justification, so retrospective justifications for racial difference, but also about establishing the best genes. Now, what this did was created racial hierarchies, and it in particular put whiteness at the top of that hierarchy. So in the way the world is raced now, we have both whiteness at the top of that hierarchy, but whiteness is also invisible because whiteness is the norm. So we have the language in different countries. So I'm in the UK, there's a category that's Black and minority ethnic. You've also got terminologies like Black, Indigenous, and people of color. But the language of color would suggest that we're only interested in people who are quote unquote darker skinned, but that effectively invisibilizes whiteness because it makes whiteness the norm, the default. So this idea of whiteness at the top also becomes, the whiteness becomes invisibilized, but that hierarchy is very much a legacy and indeed a continuity from colonialism because of the science of eugenics. That ultimately then was picked up by the Nazis, as we know, with continuing devastating effects. But we can look more broadly in terms of health and where coloniality has affected how we think about health. So historically, medical experimentation is a very good example, not just about racism in health, but also intersectionality. That is to say, how we think about race, sex, and class interacting. So historically, experimental treatments on the bodies of both the poor and the enslaved, both in the West. So you had, say, the poor in what would have been Victorian London, i.e., people who lived in London under Queen Victoria's reign, but also in the colonies. Stanford historian Londa Scheibinger also talks about slaves as guinea pigs for smallpox experimentation in rural Jamaica in the 1760s. And slaves were not alone. Many poor souls were subjected to medical testing in this period. So we had drug trials that tended to over-select subjects, both in Europe and in the American colonies, that were poor wards of the state, such as prisoners, hospital patients, and orphans. We can also look at technological intervention. So often we'll think of, say, life-saving drugs, but many of the life-saving drugs that we've come to depend on actually have their roots from what were deemed at the time New World plants. And there was a history of taking those plants and the knowledge of what we might call now indigenous knowledge, turning that stuff into some sort of medicine or medical intervention, but also erasing the people from whom that knowledge was taken, in particular indigenous groups or First Nations groups in North America. But we also have a culture of sort of dealing with symptoms rather than prevention. So if we think about, health budgets in lots of Western contexts, they tend to be intervention oriented, whereas budgets for public health will tend to be a lot smaller. We're not so good on what we've come to call the wider determinants of health. There's a tendency for health to be individualized, so focusing on individual well-being. We're not so good at the relational. And interventionists, we tend to call the doctor as part of the expectations of health. Again, not so good on the wider determinants. Next slide, please. So why is this important? Well, we need to think in terms of equity. We need to understand intersectionality, which is to say, building on Kimberly Crenshaw's work, trying to understand different ways in which our identities are co-constituted. And for the purposes of equity in health, we would need to understand that if we were to actually deal with people's health concerns in a sensitive way. We need to understand how people's identities are what she called co-constituted. So Crenshaw was very clear. This is not about layering inequality. I know I'm this, and then I'm this, and then I'm this. It's not adding up to a cumulative burden, but rather shaping unique experiences of oppression or exclusion. I always put myself in this frame as an example because I have privilege as a global North academic, but I'm also of South Asian descent. So I have advantage and disadvantage, but then I'm also Canadian. So that gives me, and British, so that gives me certain advantages. So my identity is not so clear, but I am one person. So my identity is co-constituted. So the idea of intersectionality then is really, really valuable. What are the implications then for equity in health? Well, let's look at this by applying a lens. So we see sex and gender as reasonably fixed space categories, particularly in health and global development. But equity in KM and health means we need to unpack who exactly we are talking about. How do we use equitable KM approaches to understand the intersectional experiences of those people we may be working with or supporting? So here, let's bring together what we've talked about so far to consider an intersectional lens that looks across race, class, and gender in health. So on the top left of the slide, you will see, sorry, next slide. Sorry, I'm moving slides. Sorry, Emily. So at the top left of this slide, you will see a painting by artist Robert Thom from the 1950s. And it's the only known representation of three slaves, Lucy, Anarcha, and Betsy, being experimented on by Dr. James Marion Sims, also known by many as the father of gynecology. But part of what he was able to achieve in gynecological treatment was done without consent on the bodies of enslaved Black women. And there are a couple of things to note here. The first is the lack of consent. That there's a history of that. We can see that in, some of you might be aware of the Tuskegee study in the US of Black men, also done without their consent. They were lied to about how their syphilis would be treated. But also an assumption here that this was these women's bodies were good to experiment on because of the assumption that Black women don't feel pain. So it's deeply racist, it's deeply prejudiced, but it also says something about then who gets to be, whose pain, whose health considerations are actually part of our deliberations within our health practice. So when we also consider that caring labor is done disproportionately by brown and Black migrant women, both paid and unpaid, a point made by Barbara Ehrenreich, who recently unfortunately passed away, whose scholarship in this area is also really, really good. We can see the legacies of that in the pandemic, in the COVID pandemic. Some on the bottom left, you'll see reporting on COVID-19 disproportionately affecting Black, Indigenous, and Latina and other quote unquote people of color the most. So uneven distribution of poor health outcomes has race and gender dimensions. But to understand that, we need this intersectional lens. And if you think that this kind of experimentation on either without consent on brown and Black or othered bodies is a thing of the past, I will point you to the article I've put at the middle of the slide, which is during the pandemic, there was a discussion on French television by a comment made by Jean-Paul Mira, head of the intensive care unit at the Cochin Hospital in Paris. Cochin is also a place in Kerala, so there's a bit of coloniality as well. But he said, and I quote, "It may be provocative," and he's talking about drug testing, so potential COVID drugs. He said, and I quote, "It may be provocative. Should we not do this study in Africa where there are no masks, no treatment or intensive care, a little bit like it's been done for certain AIDS studies where among prostitutes, we try things because we know that they are highly exposed and don't protect themselves." So here again, we're getting this absolutely deeply racist and awful rhetoric, but it's seen as completely normal, to homogenize Africa as if it's just one place as opposed to a deeply diverse and dynamic place, but also that we can continue to just experiment on these bodies until we get the right treatment, which would then be given to the global north. And I would finally draw our attention to, again, the coloniality of how gender is thought about, because in this context, then some people just don't get to be women. Right? So the idea of cis-het, meaning if you're biologically deemed to be sexed as a woman at birth, within development, we're very keen on sexual and reproductive health, but there is a tendency for that to focus on heterosexual women and girls in their reproductive years. We're not so good at talking about older women. We're not so good at talking about LGBTQ people, and we're not good at talking about sex workers, who are always considered in those categories, not women and girls. So gender as an organizing principle, quoting Oyuwumi here from Lugones, sort of saying that actually in Yoruba society, gender was not an organizing principle. So we mustn't presume that either that these are fixed categories or that it was always historically so. This is not true. Next slide, please. So what are the implications for us in terms of equity in KM? Well, we need then to think about how we know in development institutions. And here I would draw our attention. None of this is going to be new to any of you, but it's really important to highlight it because we need to identify it if we're going to address it. So we need to accept that we live, that we work and live in institutionalized structures that are deeply hierarchical. They're what I would call professionalized. So it doesn't, the irony for me, for instance, and the KM success team making translation available, brilliant. And that is a really important first step. But in lots of spaces like this, I would be speaking in English and you either know English or you're excluded. And it's not just any English, but a highly professionalized jargon English. We tend to work in spaces that are competitive, not collaborative. We don't have the tools to think about the politics of what we call development, where there's still a tendency to look for the technical solution, you know, the well-placed school or the well or the health clinic that's going to solve all the problems outside of thinking about the political and social and economic context that we're working in. There's also the language, as I've just said, about English and that particular professionalized jargon English. And also what I've noted, this tendency for there to be a universalized Western framework. So we tend to think about, and the SDGs is the best example of this, where we have a fixed idea of what a good life looks like, and that tends to come from the global north. And also our tendency to use homogenous labels, who is the grassroots, where is the local? We tend to use these shorthands that will then homogenize places, like we saw with that quote Jean-Paul Marat talking about Africa in the, as a homogenous entity. Next slide, please. So I'll conclude here as a way of starting our conversation to think about why equity in KM matters. I have always been wary of the us and them tendencies in development studies, and I am excited about the possibilities that goals like the SDGs offer to have a truly global conversation about the kind of society that we might work to collectively achieve. But this requires a continuous reflection about the range of voices and ideas we seek out, as well as how we gather and then choose to present them, and also to codify them. We need to consider the implications of our methodological, but also delivery choices, particularly in the context of health, and the assumptions that underpin these choices. So when, for instance, we seek out local voices, these are not more authentic. These do not exist separately from the mainstream or represent separate life worlds. And I'm also interested in thinking about power and the coloniality of power. Can we actually understand, how the colonial legacies are playing out in our work? An example that I always like to point to is how we think about the global south. So there's a tendency to think about the global south as part of the local, and it's only the global north that is allowed to have a commentary on the world. And I say that as somebody who is invited to do that myself. So I'm allowed to think big thoughts about, global issues, but people are only brought in to represent. If you're from the global south, you're only allowed to talk about your little part of your part of the world. But what if people from the global south, including the people that we are interacting with, are also experts in their own right, are also knowledge holders, have something to say about the global north? How power functions, if we can think through that, we can start to unpack it, and then we can start to challenge it. We can upend those the coloniality of the power relations that within which we work and live. And it's a really important question for us working in communications. How do we listen? And what might this mean as we seek to, quote unquote, decolonize development, as Rueda said, is part of our collective journey here? Why might this matter to equity in KM and in health in the space that we work? And how do we make that relevant to everyone? Next slide, please. I'm going to leave it there. I'm hoping I haven't gone over time too much, but if there are any questions, please put them in the chat. This is just the start of a conversation. This is a process, not an outcome. And I've covered a lot of material, and there's many more discussions to be had in this space. Please put your questions in the chat. I will get to as many as I can, and any that I don't get to, I'm really happy to try to pick up in the Q&A. But thank you so much, and I'm going to turn over to Rihanna.
Thank you, Dr. Narayanaswamy, for setting the stage for us. I will briefly go through Knowledge Success's understanding of equity in knowledge management, or KM, and how we have thought about integrating equity within KM. Next slide, please. Before we dive into what equity in knowledge management means, let's briefly touch on what knowledge management means. At Knowledge Success, we define knowledge management as a systematic process of both collecting knowledge and connecting people to it so they can act efficiently and effectively in their work. We believe that knowledge is one of our most valuable assets to addressing global health challenges. What we know impacts how we take action, and how we manage knowledge can affect individuals, programs, and ultimately health systems. Knowledge management can improve coordination and enhance meaningful learning among health professionals, ultimately leading to improved health outcomes. Many of us practice knowledge management every day without realizing it. when healthcare providers refer to the latest guidance on how to treat a disease, or a program manager reviews health systems data in order to inform their programs, or when a technical advisor joins a working group meeting to share implementation details with external colleagues, they are all using knowledge management. In each of these examples, health professionals are collecting knowledge and connecting people to it. Knowledge management, or KM, helps global health practitioners share and apply valuable know-how in their work. And the results are a stronger health workforce, better health services, and longer, healthier lives. Next slide, please. Now, let's get into the topic of equity. Many of you may already be familiar with what equity in health means. According to the WHO, health equity is the absence of unfair, avoidable, and remediable differences in health status among groups of people, whether those groups are defined socially, economically, or geographically. Health equity is achieved when everyone can attain their full potential for health and well-being. There are many differing viewpoints about the image on this slide. For today, the image is a reminder of the difference between equality and equity. With equality, everyone is given equal treatment, but with equity, the focus is on equal outcomes and recognizes that some groups may need more support or resources to achieve the same outcomes due to social injustices that they may be experiencing, such as discrimination or poverty. Next slide, please. Now let's move on to equity in knowledge management. We define equity in KM as the absence of unfair, avoidable, and remediable differences in knowledge creation, sharing, access, and use among groups of health workforce members, whether those groups are defined socially, economically, or environmentally. Does this sound familiar? We drew heavily on the WHO definition of equity in health. The key point here is that the programs need to address the unfair and avoidable differences among groups of health workforce members that are rooted in social injustices such as discrimination. Equity is achieved when all people in the health workforce have the information, opportunities, skills, and resources they need to define and participate in knowledge access, creation, sharing, and use to improve health programs. Next slide, please. So how can equitable KM improve health programs? We view diversity and inclusion as tools to help us achieve equitable KM systems, processes, and outcomes. This means intentionally including all members of the health workforce in KM and valuing their skills, ideas, and experiences, as well as including diverse people in leadership and decision-making roles. With this intentional focus on diversity and inclusion, we can help shift negative and detrimental forms and effects of power over individuals and groups towards positive expressions of power and agency, including power to take action, power with others to take collective action, and power within to recognize your own self-worth and capacity to take action. These shared power structures and inclusive approaches, in turn, will create more equal KM outcomes across the health workforce and ultimately lead to improved health programs. Next slide, please. This is the 5-step KM roadmap that is found in Building Better Programs, a step-by-step guide to using knowledge management in global health that was recently updated with equity integrated throughout. We used this 5-step KM roadmap as our framework for integrating equity into KM and have included equity considerations in each step. You can find our detailed guidance in the Building Better Programs Guide or the shorter version, the Pocket Guide, which are both housed on the KM training package website. My colleague Natalie will be dropping the links in the chat. I'll go through a broad overview of how we thought about integrating equity within each step. First, in step 1, you would assess how knowledge needs, barriers, and opportunities may vary depending on people's intersecting identities. So who is experiencing inequity and which aspects of KM systems and processes are not being delivered equitably? So when we say intersecting identities, we are referring back to the concept of intersectionality just discussed by Dr. Narayanaswamy. This lens prompts us to assess more specific communities, the needs of more specific communities. So once you've assessed the information needs with an equity lens, In steps 2 and 3, you would now design and implement KM interventions that address the barriers and root causes of inequity that you uncovered in step 1 in your needs assessment. Finally, monitor and evaluate implementation of the KM intervention and make any necessary mid-course corrections to ensure all people can engage in that intervention. So we have 2 main tools that can guide global health workforce members in this process. Next slide, please. The first tool is the KM for Global Health Logic Model, which some of you may be familiar with. It was developed by the Global Health Knowledge Collaborative to assist with planning and evaluating KM interventions in global health programs. As with other logic models, it provides a visual depiction of the inputs or the investments you put into, in this case, KM initiatives, the processes you follow, and outputs you create. And finally, the outcomes you expect to achieve as a result of that work. A big part of the updated edition of the Building Better Programs Guide includes an updated version of this logic model with equity considerations integrated into it. So equity considerations flow through each stage. So we see a bit of that flow with the key equity prompts on the next slide, please. So with each stage of the logic model, we noted how equity plays a role in what a health workforce member might ask when in that stage of KM. So this is not an exhaustive list of questions, rather something to get someone thinking about equity in each stage. These prompts bring out questions of power, decision-making, and value, especially in the inputs and processes stages. These prompts are closely linked to the checklist that we will talk about next. So for example, in the input stage, some of the equity considerations you'd want to take into account are whose voices are included or excluded in KM systems, and who makes the decisions on the kinds of data and information that are being captured. Similarly, when you're looking at the processes stage, consider who is involved in generating new knowledge, synthesizing that knowledge, and sharing it. Are power and privilege influencing those decisions? The logic model is useful both when you are in the earliest stages of planning a KM intervention by assessing the needs of your health program, and towards the end when you are evaluating. When considering your KM outputs, the KM events you convene, the products you develop, the publications and resources you publish, you want to consider the 4 essential elements to ensuring they are effective and equitable. These 4 elements are availability, accessibility, acceptability, and quality. So KM tools and techniques should be available to all members of your intended audience, accessible to everyone at no or reasonable cost and consistent with their needs, acceptable in that they are respectful of culture and sensitive or responsive to people's identities, and do not reinforce inequitable gender and other power dynamics. And finally, they're of high quality. That is, they're accurate, up to date, unbiased, and relevant. So these 4 elements draw on the global health field's essential elements of health services. In all, the updated logic model with the equity prompts can be used as an organizing framework when planning your KM initiative or when monitoring or evaluating it. Next slide, please. So the other main tool that we've created around equitable KM is a practical checklist to assess equity in KM initiatives as you are designing and implementing them. This is something that our own project staff members were asking for. And we also heard from colleagues in other projects and other organizations that a practical tool like this would be helpful for their staff as well. So we want to state a huge thanks to the many, many people that have reviewed this checklist and shaped it into the version it is in today. So it is absolutely a living document because we are still learning about this. The checklist, which aligns with that KM roadmap I spoke about earlier, is a reflective tool with the goal of raising awareness about potential inequities in KM and suggesting how those inequities can be addressed. Another goal of the checklist is to assess strengths and weaknesses in a KM initiative as they relate to equity and identify where to focus your efforts to achieve more equitable KM. The checklist has an accompanying how-to guide, which gives more context to each of the questions. So while the KM for Global Health Logic Model helps spur thinking on equity, the checklist provides more specificity in addition to the equity prompts in the logic model, so they can be used together. The checklist is most valuable when used as part of preparation and design before implementing your KM initiative within a global health program so that you can plan for equity and success at the beginning. But it may also be a useful tool for reflection during implementation of a KM initiative or retrospectively after it has ended. You can also find the checklist on the KM training package website, and Natalie will drop those links for everybody in the chat. And with that, I'll turn it back over to Rueda for our next segment. Thanks.
Thank you so much, Rihanna, for walking us through some of the tools that we've recently published to help us achieve equitable KM interventions. And thank you everyone for putting your questions in the chat. Please continue to do that and we'll make sure we get to your questions and answer them in the final Q&A session. At this point, I'd like to invite my colleagues, Gaio, Irene, and Isatu to share their experiences on some common equity-related challenges that they've encountered in their KM work in their respective regions. So let me start with you, Gaio. Gaio, as part of your role as a KM officer for the Knowledge Success Project for the Asia region, you host a lot of online events. So these range from online workshops to strengthen health professionals' capacity in KM, to bringing family planning and reproductive health professionals from various countries together to share what's been working well in their programs and what hasn't. I know these online events have been a very cost-effective way to bring stakeholders from various countries together in one space. And they've opened us opportunities to us that we didn't have in previous years. But I'm curious to know, have you encountered any equity-related challenges in these types of events?
Thank you, Rueda. So for everyone to understand, I'll give a context of one of the activities, online activities that we are doing. So it's called the Learning Circles. And this Learning Circles, actually, it's a knowledge management innovation that provides space for participants to explore, brainstorm, to build and share experiences and practical knowledge on a particular or specific family planning or reproductive health issue. So if you would take a look at it, it actually provides equity because we were intentional actually to being inclusive and ensuring that there's diverse participant and we are conscious of their access to technology. However, some of the challenges that we've encountered or I've encountered personally is first, since this activity is online or virtual, it may have left out people without steady internet access. And even among those who have steady internet access, there are still those who are in the category of tech savvy and not tech savvy. So there are those who know to use applications that we are using, like WhatsApp or how to use the Google Drive, the Google Jamboard. But there's those who still need some hand-holding in accessing these kinds of platforms. Also, since these activities usually requires talking to people in other countries, so it requires a certain level of fluency also in English to be able to express themselves and also to understand or comprehend what other participants are sharing or saying. So, and we know in Asia, there are many different English accents as well. So there's difficulty of people understanding each other. And there's also a tendency, like probably if someone from like what Dr. Lata said earlier, from the global north, listening to the event itself, they might think that it's nothing new. But for participants who are there, it could be something new for them. So it could be something practical for them. So these are some of the challenges that I have encountered during this online events in terms of equity.
Thanks, Gaio. And that's actually really an interesting point that you raise at the end too, and in that, this kind of perception of what's important to share and what may already be known. So something that may be known to me or you or to someone else, it may be something new to a different person. So that's, I'm glad you raised that issue. Gaio, I also know that you and your team recently used the equity checklist that Rihanna just shared with us to take stock of these online events and particularly learning circles. So is there, can you share with us some of your experience with using the checklist? What was helpful about it? What might have been challenging for you when using that checklist to assess the equity in learning circles?
Mhm. So, for someone who might be new to the definition of equity or seeing the checklist, it might seem overwhelming, but it's actually helpful because personally for me, it made me more conscious of how to do it right the next time and how to be more intentional in applying equity. Although we do it during the planning, but still the checklist helps providing a guide on what to think about in terms of equity. And although the checklist, we saw it, we used it like after the event, it also made me reflect on how we could do it better the next time and how to be again the word I always want to say is intentional in applying equity. Although however, fully applying it still comes with challenges, like given the realities, like for example, conducting activities in a virtual setting that leaves out again those who have not access to technology, wherein sometimes most of the time we don't have control of. Um, but after, together with the team of those who facilitated the learning circles, as we reflect on the equity checklist, we realized that actually we are pretty good in applying equity. Like we did consider like the levels of influence or power, like who should be included in the as participants. We were saying, oh, let's why not choose also those mid professionals, program managers, and then also we analyzed also their knowledge needs, their preferences, and their barriers to participation. We also consider the varying levels of their access to technology. So we said, okay, those who will be joining with mobile phones, this is our strategy. So we were conscious of that. So we were happy that we are following some of those in the checklist. And then something that we could improve on probably was being more in depth in those intersecting identities, like probably a program manager, yet doesn't have access to a reliable internet connection. Just as an example. And we were also we also ensured that we were interactive given the different types of audience. We were also intentional that it was convenient for the participants, like the time zone and the dates, that it doesn't fall into a holiday of any country. And during evaluation, we also engaged all team members in creating the evaluation question. And like what Dr. Lata said, we do ask content. Every time we will be using photos or quotes of any one of the participants, and we ensured safety as well. And all of these are in the equity checklist. But of course, there's still some room for improvement, like being intentional and explicit, really in including equity in planning any KM activity. And at the end, also intentionally including equity when reflecting on how to strengthen it better. Also, providing briefing notes to align all of the facilitators with equitable KM. And also, something to consider is probably using language beyond French and English in facilitating learning circles, or using sign language to include those people with disability. And another thing is room for improvement would be in being intentional in including standard equity indicators to help in monitoring the KM activity.
Great, thank you, Gaio. That's a lot. And I think that's the point of the checklist, is that there's so much to consider when thinking about implementing equitable interventions. And so maybe that's what's the helpful part about the checklist, is that it's like a prompt for you to consider. the issue from different angles. Great. Now I'd like to turn to Aissatou. Aissatou, you're based in Senegal and you work with family planning professionals across the Francophone Africa region. We've heard from our colleagues in the region that there are major language considerations that the family planning field needs to take into account. Can you share some of the challenges that your French-speaking colleagues may encounter in their KM work?
Merci beaucoup, Ruaida.
Thank you very much, Ruaida. I think that, as you have just said, in the Francophone regions, we have the main barrier with regards to our work in knowledge management. It is a linguistic barrier. As Dr. Lata said at the beginning, we know that many resources are available only in English. And so now we are trying to think more about translating these resources to spread it to other regions in the world. But we still have a very significant gap. The availability of these resources in French. This can also encourage more knowledge management in Francophones. We need to make sure that these resources are available in different languages. We have we have a lack of these resources that are available in French, and that can hinder the development of these skills in Francophone regions. We have also noticed that in knowledge sharing sessions, there are many webinars or many even in-person seminars and workshops that there needs to be more effort made for translation and participation, and we need to encourage Francophone people to participate. They can listen, they can learn a great deal of information, but they also need to feel empowered to speak. And it's not always easy for them if you don't have this translation service. It is good to have the slides in English. Of course, it's great to listen, but everyone would like to be able to read the slides in their own language. We want to be able to have these explanations, these written explanations in French as well. This is one of the most significant challenges that we face, particularly in Western Africa. We have both Anglophone and Francophone countries, and so this language obstacle is very significant here. Many Francophones feel obligated to stay in their region and only exchange with other Francophones. And that's not the ideal. We want a global exchange. We want more exchange between different people with different languages. So that truly is one of the most significant barriers for the Francophones in our region.
Merci, Aissatou. And
thank you,
I just
Aissatou.
want to say that you actually helped remind us. It's always a pleasure having you on our team because, I will say that as we were planning for this webinar, we overlooked having the slides in French until Aissatou reminded us to do that. So this is again another reason why something like the checklist, if you refer to it continuously, can help you to think of all these equitable aspects. And so Aissatou, I wonder if you can point to a good example of a knowledge management activity that was equitable, especially in taking into account the language considerations.
Of course. I'd be delighted to. There are many, many examples in the context of the Knowledge Success project in the region. There is a greater availability and accessibility to the information in French, but there is also a rather new activity that truly took into account this barrier of language. We've had this issue with countries such as Nigeria and Senegal on self-care. it's not very recurrent to see bilingual interactive activities. So it was a true challenge, but we needed to share the experience from one country to the other in order for the country to be pulled into the success in between Nigeria and Senegal. It was greatly appreciated because, as I said, it was rather unusual to have two groups exchanging in one language or in another. It was a greatly appreciated activity, and it is the type of initiative we need to multiply. Language should not be an obstacle at the level where we are. We should be able to give the opportunity to the French speakers as well to express themselves in their language on important question, and also to have those interactive activities between countries so that there can be an exchange of experiences.
Thank you so much, Isatu. Thank you for sharing that example of I think it was a peer assist activity where between two countries in two different languages. So thank you for that. Next and last but not certainly least, Irene, you're based in Kenya, and similar to Isatu and Gaio, your role is to help family planning professionals in the East Africa region to find and share and use knowledge to improve their programs. Have you also experienced similar types of challenges that Gaio and Isatu refer to, or are there other types of challenges and solutions that we should also be taking into account?
Well, I think with the language barrier seems to be a cross-cutting theme only for East Africa. It is assumed that we are Anglophone, and it is true. Nearly all the countries that within the region have English as the national language of formal communication. However, within this region, Kiswahili is also a language of communication, and it's what is popularly used at least in 3/4 of the countries. So we have faced challenges in terms of our participants expressing themselves, while they can be able to understand the information that is being disseminated to them in our trainings, in our webinars and all that. They would wish to actually be able to participate with a language they're comfortable with so that they can be able to express themselves better. There's certain terms and certain expressions that cannot be directly translated into English to mean the same thing, especially in family planning and reproductive health. So that's one of the challenges that we have gotten in small group meetings or even larger gatherings in which we disseminate information and training on knowledge management for family planning and reproductive health. So we actually did have a testimony in one of our check-ins with the Learning Circle participants, where he was very, very happy about the amount of knowledge exchange that happened, but he felt that he did not have the opportunity to express himself in the maximum capacity he could within the group sessions that we were engaged in. So that's one of the things that we will continually work on within the sessions that we hold in East Africa.
Thank you, Irene. Yeah, I think that's actually really important. We assume that, Anglophone Africa is English speaking, and of course they are, but I think across the board within Asian countries, within African countries and others, that the people feel most comfortable expressing themselves, especially in discussion formats in their native language. And so it's really important to give people the opportunity to do that. So thank you for that. Are there any other types of challenges or solutions that you've encountered in your region that you'd like to speak to?
So we have had an issue in terms of access to data, and this is also comfort with technology and preference on platforms which our practitioners prefer to communicate in based on their 8 to 5 jobs and also the situations at home, depending on when it is that we access them to disseminate information. So in one of our platforms, which is a community of practice, and to address the same stakeholders in family planning and productive health within the region. We had designed a web platform in which we would have online conversations and discussions on matters that are hot and hip within the family planning productive health sector in the region. While this was a very good initiative, in one of our conversations, in one of our meetings, quarterly meetings, some of the participants actually suggested that we open a WhatsApp group. And the reason why they preferred that is due to the flexibility of access to technology. Most of them are nurses, doctors, midwives, some are teachers, some are working an 8 to 5 job, some are doctors. And while they have active hours, they really don't have time to go into the web and access and contribute to the conversations that we are having, which are very pertinent to drive the agenda of family planning productive health within the region. So it is common, I don't know if it's the same in other regions in Africa and also globally, that internet service providers within the region provide extra data as part and parcel of encouraging people to communicate through the WhatsApp platform. So this happened to make it easier for these individuals within the community of practice to be able to access the same conversations that were happening on the web platform during their off-peak hours and while they were going home, and they could contribute to the conversations. The other thing is actually creating the WhatsApp platform. Because data is free or it's subsidized on WhatsApp through this internet service providers, this happened to complement access to information and conversations that were happening within the web platform. And we've seen the members grow and being more free in contributing to conversations on family planning productive health within the region and globally as well, because they share updates, events, calendars, and it's easy. It's just with a click of one button, the information is there, and anyone who's interested in asking questions can be able to get an answer almost immediately, as opposed to them going to the offices to find a computer and be able to get that information. So we facilitated cross-posting of information on different platforms through these WhatsApp groups. And we do have several groups because it was a best practice and it worked very well. For the other groups which we have, like Knowledge Management Champions, the FP 2030 Youth Focal Points, we're using this platform and we're finding that they are appreciating that access to information.
Great. Thank you, Irene, for sharing that important issue about technology and using technology where people already are and can access that information. I think at this point, we'd like to open it up to answer questions from the audience. So we will definitely feel free to put your questions in the chat, and we will try to take as many questions as possible. Maybe I can start by, there was a question in the chat about, can we ever have equity in access to health information? So maybe that's a good question to start. It's very broad and a little bit challenging, but are we ever able to really have equitable access to health information? So perhaps, Rihanna, I can call on you first and see what you have to say about that question.
Thanks, Runa, and thank you, Ngozi, for your question. So we recognize that through this process, it is overwhelming to thinking about how to ensure equal or equitable access for everybody. We recognize that we all work within many constraints within programs and our limited budgets and scopes. So our goal in this process is to contribute to making KM interventions more equitable for our key audiences. So when we're in situations where resources are limited, we do recommend focusing on the groups that have been historically excluded or most marginalized. And I think that is a place where we are starting our thinking. Thank you.
Great, thank you, Rihanna. And just wondering if any of the panelists would like to add anything to that. Okay, great. So we'll go to the next question. I think this was toward Isa too. Could you comment on the need for materials in non-official languages? For example, Wolof in Senegal or Tagalog in the Philippines. In India, materials are now being translated into Hindi and other regional languages. So beyond, what I guess we could consider colonizing languages like French, Spanish, Portuguese, and the like. Can you comment on that, Isa too?
Thank you so much, Raida. I'm going to answer in French. You are absolutely right. It is another important element in Senegal. And it's the same in the other countries. There remain a great number of dialects. And the issue of this availability of the resources we share, for instance, in Wolof in Senegal, this is a question that is raised many a time. And I believe that at the level where we stand today, I remain convinced that the idea is to help the specialist to at least give them at first the access to the platforms and the information in French so that they can have them. And then in turn, they can take care of the translation in the local dialect so that the community can can benefit as well. Efforts are being made. A lot is translated in the various dialects in Senegal, but it is not enough. And today, I believe there is a true need, and we are working to the mobilization of these resources in French so that they are accessible then in the dialect of each country. Thank you for this question.
Thank you, Isa too. Much appreciated. Okay, so for our next question, this is about menstrual hygiene programs and male involvement. So the question is, most times partners and projects provide menstrual hygiene packs to girls. There is a minimal boys involvement yet they have adolescent related needs. What ways can we ensure boys or male involvement at this level? So I was wondering if any one of our panelists would like to take that question.
I'm happy to start and maybe ask if others would like to jump in.
Great.
So thank you for this question. When we were starting to look at this question, we might want to think about where we're starting our thinking might be examining those power dynamics within the program staff and the males and boys living in the communities. And so we might use the questions that we've been thinking about of what are those power dynamics that exist? Are we extracting information from males and boys in these communities with value not being returned to communities? How can we restructure that extraction to become more equitable? I don't know if I have an answer necessarily, but these are the types of questions we are thinking about to try to shift from that power over individuals to power with other individuals. And how can we think about which, maybe not boys and males broadly, but what specific boys and males are not being heard currently? And that might be another question that we can start asking ourselves.
Thanks, Rihanna. I think it's always helpful to come back to things from an intersectional lens, and it really helps to pinpoint more specific problems and challenges, and really try to be very mindful of the particular needs of groups of people. So thank you for that. Would anybody else like to add to that?
Me?
Okay, go
Since
ahead, Kyle.
recently it's the topic for Asia on how to engage men and boys in family planning and reproductive health. So the question is, what ways can we ensure boy or male involvement at this level? So this advice I'll be giving is not from me. It's from those participants in the learning circle. And they would always say that to always understand the issue from the point of view of the male and also to see their needs. Like, for example, there are not much male providers at the community level. So probably it would be possible to have more, let's say, male providers at that level, and also to emphasize the value of benefit of understanding the importance, let's say, of these hygiene kits and what's in it for them, even if they are boys or male. So, and also using a platform where it would be more popular among men and boys, or using the male lingo or language during discussions of family planning and reproductive health issues. So these are just some. There are actually many. And check it out in the upcoming article. It will be soon on the website of Knowledge Success. So that's it for now.
Great, thank you, Gaio. It's nice to hear that something that you've been digging into in the region as well. The next question I wanted to pose here comes from Paul Atwine. He asks, how can we encourage KM materials to be repurposed for local contexts and languages without raising copyright issues? So that's a very, very good question and very challenging to deal with copyright issues. Maybe I'll just start and see if others have any ideas, but I think one nice thing is that in the international health, the global health and development field, we tend to be very open in terms of wanting to share materials and wanting those materials to be repurposed. So I think many organizations would very much welcome that repurposing. I would say if you are worried about copyright issues, you could definitely reach out to that organization, the publisher, and ask, we'd love to translate this resource into a different language or to repurpose it. Do we have your permission to do that? And I will say from our experience at the Center for Communication Programs, we publish the Family Planning Handbook. And, it's been translated into many languages by our organization, but some of the languages that it's been translated into have been from people who have actually done that. They've reached out to us and said, can we translate this into such and such language? And we very much welcome that. We very much appreciate that because we want to get this out in as many languages and to as many people as possible. But, we all work within constraints of limited budgets and limited scopes. And so we can't obviously translate it into every single language. So I would definitely encourage folks to reach out to organizations and publishers and see if they're open to having that translated into another language or repurposed. And, there is, issues maybe of like quality control and making sure that nothing gets lost in translation, but perhaps, opening up that discussion to see how best to reach that goal. Dr. Narayanswani, yes.
Yeah.
Please,
No,
go ahead.
thank you. I actually wondered if I could quickly ask a follow-up question on that, only because I'm interested from our expert panelists about whether there's also something about formats, because obviously things are written and so we can provide a translation, but is there scope for us to think about whether we need to demand resources to disseminate differently? That's sort of my feeling in thinking about the work I've done in this space, but ultimately I'm coming at it sort of with an academic hat on. And I would love to hear from all of you about, what sorts of things, would be helpful and what kind of resource would you need for that? So pamphlet might be okay for some context, but maybe you need a different mode of communication entirely. And I would have thought our attendees in our session today would also have views on that. If you had, please pop it in the chat. So I'm wondering is that okay, Rueda? I was just thinking in terms of just this conversation about translation. I just think it's so interesting to also think about how we're communicating and whether
Mhm.
our expert panelists have some insights on that, or whether any challenges they've overcome around that.
That's a
Thank
great
you.
question. Yes, perfect. Would anybody like to jump in? Irene?
So we've realized that in our work in East Africa, and one of the things that we have learned is that throughout our region, storytelling is a very powerful, powerful medium of communicating family planning and reproductive health best practices, journeys, and with this, we actually do encourage our stakeholders to tell their stories and to tell their stories in different formats, whether it's oral, whether creating videos, because then again, we also have to realize that not everyone can be able to read and write. And a lot of information is passed orally and it's stored more permanently through visual consumption. So we have been able to do that. And we actually have it in our knowledge management training as one of the techniques we use to transfer information and knowledge. Another thing I'd like to say that is a follow-up for contextualization. Within this project, especially with the Learning Circles program, we've been able to take up the information and material and techniques and be able to contextualize them to the local context of the different countries and different regions so that we can be able to easily transfer that knowledge from us as a technical experts to now the professionals who we are working with, the family planning product professionals that range from youth to very seasoned family planning and reproductive health practitioners. And we've been able to cascade that information beyond the national level to the grassroots level through our trainings. So in that way, we've been able to empower our end users to be able to disseminate information further than the points of the regional lens and national lens. So that's what I can share from that.
Thank you, Irene. Thank you for that. And Isa too, I feel like you wanted to jump in as well. Would you like to add anything to that?
Yes, thank you. It's a bit along the same line as what Irene was saying. I think that what is most important, it is not simply to translate information into local languages, but is also to make sure that it is usable information. So if you can use visual communication methods, if you can visualize the information, this is a great way to communicate it. This is something that can work in other countries, but in Senegal, for example, we have information in French, but if you have it in a visual form, then poor and marginalized communities can use it because there is quite a bit of illiteracy. So it is not just to use Wolof, for example, but also to find other ways to express this information. You can use videos that are made within the community that explain and interpret different experiences. And you can also use different forms of narrative. And when you use these different forms of narrative, you can encourage different communities to share their own experiences. So you have a great deal more of sharing among these smaller communities and these different regions. And you can empower them to share their information, and they can also learn what information is important to share. So thank you so much for letting me add that.
Thank you, Isa too. Thank you. I think, yeah, all of this points to really making sure we understand our audiences and their needs and not making assumptions. And so just going back to the knowledge management process, starting with a needs assessment, even if it's a really brief and quick needs assessment to really kind of understand our key audience groups, recognizing we can't reach everybody within one specific project, but really focusing on your key audience groups and making sure you understand their knowledge needs, their preferences, how they want to receive this information, how they want to share their information, and making sure that we prioritize based on those actual knowledge needs. There are lots more questions in the chat. Unfortunately, we are coming to the end of our webinar, but we will definitely make sure that we provide written responses and send those out via follow-up in our email. We'll also provide a link to the recording of this webinar and some links to some of the key resources that we've been sharing. Before we close today, I did want to invite you all to contribute to another activity that Knowledge Success is working on for the family planning community. We believe that it's not only important to share information about our successes, but also to share our failures in global health programs so that we can learn from those experiences and avoid repeating past mistakes. So as part of the upcoming International Conference on Family Planning in Thailand in November, we'll be hosting a session where a panel of stakeholders will be sharing their experiences with program failures. We're also developing a video to showcase the many voices of early adopters who are encouraging people to share their failures, and the voices of people who are passionate about sharing failures more systematically. So we would love for you to be one of those voices. All you have to do is record a very brief 1 to 2 minute video clip of you sharing your thoughts on why you think it's important to share our failures. So our plan is to interweave your submitted video clips together to be used to promote the FailFest that's happening at the International Conference for Family Planning, as well as to show the breadth of support for this type of concept. So the video can be as simple as you recording a selfie on your mobile phone or on Zoom. It doesn't have to be anything fancy. You can find more information at the link that will be shared in the chat. And we'll go ahead and drop that link right now. And we hope to see your submissions. And maybe I'll just take a minute to drop that in the chat right now. Great. And with that, we just want to thank everyone for their participation in this webinar. And we also invite you to continue this conversation with us. Our email addresses for all of the panelists and speakers are on the slide. We'd be happy to connect with you to answer your questions and explore this topic some more. We don't claim to hold all the answers, and we see this as the start of a journey. And we are definitely looking forward to learning more about this topic ourselves through all of our experiences together. We also plan to share a list of our favorite readings and podcasts and other resources with the webinar recording that we'll send out later this week. So be on the lookout for that. And thank you again for your participation. We hope you have a wonderful day.